Hello everyone, this is Mary Gregory with MAS Coding Solutions. Oh my gosh, it is summer here in Charlotte, North Carolina. It's beautiful, it's hot, but we are so glad to be with you. Just seems like it's been a long time since I've been with you all. But here I am. Now, we're going to start sort of a new series, and it is going to be CPC certification series. And what we're going to do in this series, we're probably going to go through chapters, and we're just going to highlight for you what you need to know to be successful on the CPC certification test. Now remember, CPC stands for Certified Procedure Coder. That is a credential that is different from the CCS credential, which is your Certified Coding Specialist. And depending on where you want to go in your coding career, you will want to have one or both of these certifications. Now, personally, if you have never worked in the industry and you're not in healthcare, it is a whole lot easier if you apply yourself to get the CPC credential. So we're going to start talking about in this certification series what you need to know to be successful. Now, there are people that work in the industry. They may work in a physician office. They may work in ambulatory surgery center. They may work in the ED department of a hospital. And they may be very familiar with some things. And they don't have to have a course because they work in the industry and they don't need a course. But there are people that need a course. And you may take your course, and what's going to happen is once you I always encourage people, if you're going to take the course, you need to have your test scheduled for the very next month so that you can go from the course to taking the test. That's because that information is still fresh in your mind, and you're going to have to know that information. Now, let's get started. Now, the first thing I want to tell you is this. Any certification test that you're going to take, whether it's the CPC or the CCS, you must know the guidelines. You must know the rules. You must understand how to apply those rules. See, sometimes it is not enough to know the rule if you don't know the application of the rule. So you got to know how to apply that rule. Now, in the CPC certification examination, you are going to have to do some diagnosis coding. That's your ICD-10-CM. I am not going to be concentrating on that in this series. In this series, I am concentrating on the CPT. Because the course really, when you take that CPC test, the majority of those questions are going to relate to CPT. So you really need to understand your CPT, you need to know your rules, and the first thing you want to know when you take your test, you must know your book. Now, I always encourage my students to get the CPT professional edition book. And you know why I do that? Because it has diagrams for you in here. You may not know what the inside of the intestinal look like. Well, they got some diagrams in here for you, so you'll know what that look like. Let's see, I'm going to find a couple of these diagrams. See that diagram that they have there? It helps you. They also have notes for you in here that's highlighted. If you have just a regular CPT book, that is a book that's in totally black and white. You'll probably get bored with it, but it is cheaper than the CPT professional. But if you're going to come into this business and you want to be a coder, then you must be willing to spend some money on you. You may have an employer that may buy your books. But you also may have one that say, look, we got this on the encoder, we're not going to buy books. So you got to be willing to invest in you. So I'm actually going to skip over anesthesia I'll probably do that at the end. And we're going to talk about the integumentary system. Now, integumentary is the skin. That's your skin. It's called integumentary. That's the official medical name. Now, in the front of, before you get to integumentary, you got some CPT surgical guidelines. I'm not going to go through those guidelines, but you better go through those guidelines. And you better know how to take those CPT surgery guidelines and apply those guidelines to every chapter that it is applicable to. Okay? So let's get started on the integumentary system. The first thing you have to remember is that in every chapter where it's relevant, CPT start out the same way. It start out with maybe minor procedures. It may start out with procedures that go from the top layer of the integumentary all the way down to the bottom layer. In the integumentary, they count the skin, they count the subcutaneous tissue, and they count what we call fascia, F-A-S-C-I-A. Muscles have its own chapter. So anytime you're working on the muscle, you shouldn't be in integumentary. Okay? So in integumentary, that if you open up your book, if you follow along with me in your book, you have surgery. Under that you have general. You have two codes, and it talks about needle aspirations. Okay? Now, the one thing I want to draw your attention to is this. Underneath that code, they have some rules, they have some guidelines, they got additional information for you. You need to read that information, and you need to follow what it tells you to do. This is why so many people, I think, miss the test. They get too many wrong. It's because you are not following what it tells you to do. So you got to learn how to do that. Say, for example, under this, they said for placement of a percutaneous localization device. And they said, look, if you don't know what that is, we're going to give you some hints. It could be a clip. It could be metallic pellets. And notice, this is localization during a breast biopsy. They are telling you, if you have a breast localization procedure, do not use 121 and 122. Do not use one of those. And that's the key to not only passing the certification test, but that's the key to being a great coder. See, you gotta follow instructions. See, in today's world, everybody want to do their own thing. When it comes to coding, you can't do your own thing. You have to follow the guidelines. And then, of course, they got underneath that, they got introduction and removal. In this area, they talk about, once again, sometimes a patient may come in with a cyst that has to be drained. Then it may be in this chapter. Always pay attention to some of the wordings that they may have. Because if you went there, it says, look, this particular code is applicable to a cyst in the soft tissue. And they said, look, most soft tissue is going to be in the extremities. It could be in your abdominal wall. It could be in your neck. But any soft tissue that needs draining, you're going to be over here because soft tissue, fascia, skin, subcutaneous is in this chapter. And then it has I&D, incision and drainage. They got simple and they got complex or multiple. The key to passing that test is this. They may not tell you it's a simple drainage. See, this test is designed to make sure you got some critical thinking skills and you know how to read the information that is presented to you. So they may just say the patient came in, had an abscess on the lower leg, I&D was done. It may not say it was simple. It may not say it was complex. And see, CPT editorial board say, look, complex is defined by the physician. But another little key word that is complex or multiple. Multiple mean more than one that was drained. So if you had somebody come in with an abscess, they got one on the right leg, one on the left leg, and they drain both of those, now you have multiple. See, and that's how you have to think. And just be guided by the rest of the terms. On the debridement. Debridement is key. You gotta know when to code that debridement. You gotta know how to code that debridement. They got the instructions right here for you. Follow your instruction. You always code your debridement to the deepest level. So skin is your top level. Subcutaneous tissue is next. Soft tissue, bone, muscle, and bone. So if they go down to the muscle and debride the muscle, then that's my deepest level. And so even though the physician may tell me he did an excision or the soft, he did, let me back up for a minute. He did a debridement. But debridement is nothing but an excision. That's all it is. But it's a fancy term for excision. But debridement, so when they use the term debridement, the physician used the term debridement. When they say he did a debridement, then I'm going to code a debridement. If he said he did an excision for CPT purposes, I'm going to code an excision. Now this could be a little bit different with the PCS coding. Don't confuse the two. PCS, the procedure coding system that we use as inpatient coders, their rules are a whole lot different than these CPT rules. And the two are not married, okay? So your debridement, you always code it down to the deepest level. So if your scenario said he did a debridement of the right buttocks and he debrided skin, he debrided subcutaneous tissue, he debrided fascia, he debrided muscle, even though that physician may document all the different sites that he debrided in order to get to the muscle, then the muscle will be the only one that I'm going to code. Now, of course, pay attention to your scenario. If he said he did a muscle on the leg and he did soft tissue on the left ankle, guess what? You're not going to add those two together. They're separate, see. Not because they're different body parts, but because they had different levels of depth that the physician went to. So that's what really is key, the depth. If my physician had did a muscle on the heel and debrided the muscle on the leg, I add those two together because the depth is the same. The sites are not the same, but the depth, how far down he went, was the same. So pay attention to that. They love to give you little scenarios on pairing and cutting. It's there. It's really simple. I think sometime, and they could have changed the test since I've taken it. Even though I'm a licensed instructor, they don't really tell us what's on the test, okay? Sometimes they will share with us some of the most common things that people are missing so that we can help our students and help prepare you. The other thing you want to be aware is the biopsy. When you go to biopsy, and this is so key, people are really struggling with this, whether they're inpatient coder or outpatient coder. Everything that is cut from a patient's body and sent to pathology is not necessarily a biopsy. You must know the definition of a biopsy. See, a biopsy is the removal of a small piece of tissue in order to study it and see if they need to do something additional. So so that tissue gonna go to pathology. Guess what? When somebody have a colon cancer, they're gonna cut it out and they're gonna send it to pathology. That doesn't mean it's a biopsy. And this here has a really good explanation. If you read biopsy in your integumentary system, and this applies to biopsy no matter where it's at, the obtaining of tissue is not considered a separately biopsy procedure and is not coded separately. So what they're trying to tell me is this. A patient come in and he got a skin lesion. And the doctor tell the patient, we're going to have to remove the skin lesion. We'll send it to pathology. We'll make sure it's not a cancer or something like that. So that patient is coming in for an excision. They're not coming in for a biopsy. And yes, they're going to send it to pathology. If they had told the patient, and in the documentation they tell you, we'll bring this patient in for a biopsy. For example, a breast biopsy. A lot of times when a person have a breast mass, they will bring them in. They say, we're going to do a biopsy on this breast mass to see if you have cancer. What is it? That's a true biopsy. Sometimes they'll bring the patient in and they'll tell you in the notes, we are going to excise this mass. We're going to take this entire mass out. We don't care what it looked like. We don't care if it turned out to be cancer or not. We feel that this mass needs to be removed. That's an excision. And even if they find cancer, that's not a biopsy. And so you must understand that. The next two sections, and I'm going to just kind of talk to them. You got excision of a benign lesion, and then you got an excision of a malignant lesion. Always remember, an excision involves cutting away a tissue, cutting down into the tissue. They are not going to tell you on the test that the patient have a carcinoma sometimes. What they're going to do is they're going to give you the morphological type. So if they tell you the patient had a melanoma removed, you as a coder must know melanoma is a cancer. And see, if you don't know that and you code that as a benign lesion, guess what? You are going to be wrong. So it's up to you. Basal cell, squamous cell. Go out and Google all the different types of cancer, morphological type, so you can kind of understand what those are. And when you're dealing with a malignancy, that can get to be a little touchy, okay, a little bit more difficult. So let's say your patient, we see this in the real world with melanoma. A lot of times a patient will come in with melanoma and they say, we're going to excise it. Well, guess what? Sometimes they'll do a frozen section and they'll send the frozen section off to the pathology. All this is happening at one stage. And the pathologist say, this cancer is really close to your margins. And so the physician may go back in and do a re-excision. You're going to have to add all that together to come up with your proper code. And always remember, with your skin lesion removals, with your skin lesion removal, remember this is key. Every lesion that is removed by separate incision will be coded separately, even if they're in the same anatomical site. So if they remove one from the right leg and they remove one from the left leg, that's two. And that's important because, see, when the next one I'm going to talk about is the repairs. See, repairs, you don't do repairs that way. When somebody come in and they have a cut on their left hand and a cut on their right hand, and they simple repairs, you have to add those two together if they're in the same anatomical site according to CPT. See, we know the neck and our legs are not in the same anatomical site in the real world. But in the CPT book, they may have locked them together as being in the same anatomical site. And so when they do that, and they both simple, you're going to have to follow the guidelines. And so, for example, let's look at, when you have time, you can look at this on your own. We got a simple repair. You got 12001. That's a simple repair of superficial wound of the scalp, the neck, external genitalia, your trunks, and your extremities. So if you got 1 point centimeters in all those areas, guess what? You add them together. See? And that would be your repair when you add them together. Now, if you look at 12011, that's a simple repair of the superficial wound of the face, the ears. Guess what? You cannot add, so my patient got a 2.0 of the face, a 3.0 of the leg. Guess what? I can't add those two together because according to CPT, they're not in the same anatomical site. So you always want to add together the same types of repairs and if they're in the same anatomical area. If you have a simple on the right hand and a layer closure, that's my left. Simple on the left, layer closure on the right, guess what? You can't add those two together because they're different types of repairs. Okay? So I'm not going to spend a lot of time with that. Adjacent tissue transfer. One of the big reasons people fail this one is because they will code the excision of that lesion with the transfer. And they tell you not to do that. You can't do that. So pay attention. Also pay attention to your grafts, your skin replacement, split thickness skin graft. They are not hard to code, people. You have to know, when do I need to code that surgical preparation code, which go from 15002 all the way down to 15005. The rules are in there. Read them. You know, I need to do that if my surgeon prepare this area by releasing some type of skin a release, a scar tissue release, or some type of release, or they having to clean it up. But once again, it's a little bit of a different rule if you're dealing with a debridement with that. So you always want to look at those and pay attention to that. But don't wait until the night before the test. You all need to start preparing now for these tests and looking over some of these rules. And if you don't understand them, then you're going to have to say something about the rules. Another one that they love to give you is the MOHS, M-O-H-S, micrographic surgery. They love to give you something on that. Once again, pay attention. Those surgical blocks, they may not say surgical block. He may just tell you, most of the time these this particular type of procedures is done a lot of time on cancers on the nose and the ear. And you got some very special dermatologists that perform this procedure. Not every dermatologist does this procedure. And so the one thing you want to always remember, the surgeon must be the pathologist as well as the surgeon. If they tell you that they sent the tissue off to be reviewed, you don't have the MOHS or the MOHS micrographic surgery. That surgeon have to remove it and interpret the tissue that they remove. And every time they go out and cut a little piece, that's a block, okay? So don't make things complicated. Pay attention to your breast procedure, your mastectomy, simple, modified, radical. Did they do some type of flap graft, like latissimus dorsi? Did they rotate some skin from this chest area or the abdomen and rotate it and form a breast? Always make sure that you pay attention to little words like delay. See, if you see where that word delay is in there concerning that the reconstruction of the breast, so that delay means that they didn't do the reconstruction at the same time they did the mastectomy. And so you want to pay attention to your scenario, because your scenario not going to say it was delayed. You know what your scenario is going to say? They're going to say the patient had her mastectomy 2 weeks ago, and now she's being brought back for her reconstruction. So you got to know that that's delay. Okay? So we will get ready to move into musculoskeletal. Don't forget to follow me on LinkedIn, Facebook. I think we do tweet as well. We don't do a whole lot with Instagram. Too much picture taking, and a great coder don't have time for all that picture taking. If you're taking that many pictures, you're not coding, okay? And we get paid to code. See, we don't get paid to take pictures. If you are in school, you need to concentrate on your schoolwork. You need to concentrate on your coding. You don't need to be out there on Instagram taking picture of the code book. Come on. I'm a little bit old school. People may not like that, but that's okay. And we have a website, www.mascodingsolutions.com. I'm trying to get more, I think, educational products on there for you all. I love doing what I do. I've always loved being a coder. In the next several years, I'm probably going to retire from it. And I need somebody to take my place. So come on. Get your act together. Study hard. Work hard. And become the best coder out there. You'll never regret it, especially financially. Coding can change your life. And remember this. Coders get paid to think.